Can start now.
Yes, sir. So, good evening, everyone. I'm Dr. Akshada Amonkar. On the behalf of the Geriatric Subcommittee, I welcome you all for today's session on dying with dignity. Now, we came up with this uh, topic or title. I think Dr. Nagapurkar had suggested this, and he said that this is a topic we must discuss, and he suggested the speakers also. Thank you, sir, for that, for for guiding us for that. This topic is very important because as psychiatrists also and as uh, like doctors, a lot of questions come in when dying, like the period of dying is there. When it comes to patients who are suffering and who are uh, going to lose their life, or the caregivers who are like taking care of them. Both sides, there's a lot of like dilemma, there's a turmoil, there's a lot of decisions to be made. And it's difficult as a psychiatrist or as a practitioner to answer certain few questions which are there. So for today's session, we have called three eminent speakers. Dr. Shubhangi Parker, a very senior psychiatrist, needs no introduction at all. Madam has worked immensely in the field of psychiatry. Even recently, during the pandemic, she has done a lot of work in mental illness. Dr. Shivakumar Iyer, he is the HOD of the critical care unit of Bharatiya Vidyapeeth. Sir will be guiding us about how he manages these cases which are critically ill, and he'll talk about it. Dr. Rutula Sonamane, again, she also works in Bharatiya Vidyapeeth. She is a sir's colleague, and she has done an MD in palliative care. So the three of them, as panelists, they will take us through this topic, and they'll discuss with us different aspects of dying with dignity. So over to you, sir, and the whole panel. They have got a PPT for us, which they would like to present, and they will have a interactive session. So please, you all can put in your questions in the chat box. We will either take them as they like it, the panelists, or we'll take them at the end of the session. So over to you, sir.
Good evening, everybody. Akshada has introduced me as an intensive care specialist. While it is right that I have been the president of the Indian Society of Critical Care Medicine, that was a few years ago. Following that, I've done my MSc in palliative medicine. So, I represent both sides of the coin, palliative medicine and intensive care medicine. And of course, I have with me Dr. Rutula Sonone, who's done an MD palliative medicine. So she's a rare breed because there aren't too many people who've done their MD palliative medicine. She's done MD palliative from Tata Memorial Hospital. And of course, then we have an eminent psychiatrist with us, Dr. Shubhangi Parker. While I don't know her personally, she has been ex-professor and HOD of the Department of Psychiatry at the KEM Hospital, Mumbai. And like Akshada pointed out, she's done a lot of work during the pandemic. And she also works with a lot of work in suicide and also work with de-addiction and stuff like that. The important thing is that, when I looked at Dr. Shubhangi Parker's status on her WhatsApp, it says that, we are living and dying every moment. And each moment is like a rebirth. I mean, if we can have that in our mind as we approach this topic, I think then we will have a spiritual outlook to this entire topic. And I guess that if we are able to live moment to moment and die to each previous moment, then we will not feel this fear of death, which is there uppermost in all our minds. So I won't bore you with more of philosophy. So what we will do is now I'll ask Dr. Rutula Sonone to tell us in brief about geriatrics. And I think, the questions that have been sent to me by Akshada, they indicate a certain, what shall I say, terminology in end-of-life care is such that it's very important to be precise with the words that we use. So as we go along, we might have to define some of these terms. And for the definitions of these terms, I would refer you to this excellent ICMR paper on terms related to definition of terms related to end-of-life care. So over to you, Rutula. Can you start your brief presentation, and then we will base our discussion on the two cases that we've put up.
Yes. Thank you, sir. So just briefly going over what we mean by geriatric medicine. So usually the term is used for old people. So next slide, please. So WHO came up with classification for that as well. So they've divided the elderly population in 4 categories: the young old, the old, and the oldest old. So the young old is from 60 years of age to around 74 years of age. Old would be 75 to 84, and 84 and 85 and above are the oldest old. And another classification that they gave was frail elderly, which is the age above 60 years, but having some sort of disability or mental or cognitive impairment. Now, this is important because the symptoms or the problems in each category might differ from given certain ages, and even sometimes the disease trajectories might be different in all the categories. Next slide, please. So statistically speaking, we have 10% of our population which is elderly as of 2021, which is around 138 million. And surprisingly, the males are lesser in number than the females here. So we have around 9% of them being females and around 8% being males. And this is further expected to be increasing as the years go by approximately 56 million by 2031, which would be around 13% of our population being elderly in 2031. So given the increasing number of elderlies in our population, are we equipped with managing all the problems related to their care and the special needs that they would require as they grow older? So next slide, please. So coming to the old age homes or senior care facilities or senior living facilities as it's called, in 2009, there were around 1,000, approximately 200 senior living facilities in the country. As usual, Kerala being the highest in numbers with around 182. We fall somewhere in the lower part of it, Maharashtra being 133 and Gujarat being 77 in the west zone. But from this statistics, what we can see is that they have not given many of the states of the country, like most of the states, especially in the north and the northeast part of it. And so these data might not be as accurate as we hoped for. There were another few surveys which was done for care of elderly by Tata Trust, which was quite recent, but they've just included major cities in the major states and major cities in the country. So it was not very inclusive. So as we can see, there is a huge lacuna for the care of the senior elderly people. And as of now, there is no standardization of the care provided in each of these facilities. Sorry. Can you please mute yourself? Yeah, thank you. So there is no standard set to these facilities on how to give the proper care provided, or what should be the staff which is included for in these facilities for the care of the elderly. Next slide, please. So this is one part of the problem. The second part we see are the diseases which are usually present, which would be your cardiovascular, your chronic respiratory, you have strokes and malignancies, these being the commonest diseases which lead to the death in the elderly population. And usually the disabilities seen with these would be either speech, hearing, your vision, movements, and mentation. Movements and mentation being more common than the rest of them. movements are mostly involved in all the diseases, mentation in stroke patients or dementia patients or neurological disorders. Next slide, please. So this was in brief about what is involved in geriatric care. Now I'll open this case for everyone, and please feel free
Before,
to. Yeah.
Ruthula, sorry. Before we go to the case, may I ask if Dr. Shubhangi Parker would like to make some preliminary comments? Madam? Dr. Parker?
You're muted. Ma'am, you're muted.
I'm muted, ma'am.
I think it's I would like to connect this with the whole aspect of the human right, that is a right to life. When we are talking about the death and dying with the dignity, and I would like to also say about how these particular issues can be connected eventually as we go further through the cases. I will just narrate a recent event, when I'm a animal lover, and my pet was dying. Okay, and this was in the clinic of the vet, and when my pet was at the end, basically, and I said, should I go out, to the vet? And vet said no, because let your pet die with dignity. So be with your pet, just make the life comfortable till he dies, and I think that was a beautiful way of looking at the dying with dignity. And I was there, patting my pet, and the vet was doing so many things, was giving oxygen, so death should not be restless or in the agony. So I think it's a very important aspect when we talk about dying with the dignity, is making the life till you die comfortable in a very simplest way. Thank you.
Thank you so much, ma'am, because you've set the context, and because most elderly and most patients who are approaching end of life care, they want to live the rest of their life with dignity. And an important component of that is being with loved ones and being free of pain. So I think, shall I read out the first case?
Hello, sir. Dr. Amar Shinde here. Dr. Nimesh Desai from Delhi is a senior psychiatrist and teacher for all, has also joined this program. So I think we should take his opinion also on this. And Dr. Abdul Majid is from Srinagar. He is there also. If they are available, please say a few words.
So, sure. I mean,
Dr. Nimesh Desai, sir.
Thanks, Amar. I don't know if you read my mind. Even on the Zoom chat meeting. Dr. Iyer and Dr. Ruthula particularly, don't get me wrong, but I do wish to request you to see from your experience, if you would also focus on the non-elderly population and dying experience for the person and for the family. Because till now it seems that we are kind of equating the two. And that's not always so, right? So if I can request you sometime during the course of the entire meeting, both of you with your background experience, and of course my friend Shubhangi, if you'd also focus on the people below 60.
Definitely, sir.
Yeah, as a clinical issue. Thanks so much. Thanks.
Definitely, sir, because my experience is not only with the elderly. And in fact, in India, the ICU population tends to be younger in the private medical colleges. So we will definitely touch on that. And we will look at that as well. Thank you so much, sir. Who else, Dr. Amar? You wanted someone else to also...
Yeah, Dr. Abdul, can you talk?
Yeah.
He's from Srinagar.
Yeah.
Thank you for joining.
Very good evening, everyone. Nimesh sir and everyone, Dr. Shubhangi ma'am. I would like to say that our hospital was converted into COVID hospital during year 20 and 21. So I think the meaning of life actually changed during that period. And we had, unfortunately, very undignified death during that period. As Nimesh sir was saying, it was not all about elderly only dying in isolation, because COVID was so much that time stigmatized, and we were very knowing very less about it. It was even young people or middle-aged people who were admitted in COVID wards, be it ICU or even general wards. For the want of oxygen, they were not being attended to, they were not being fed medicines. Even some of them could have been rescued easily. So it was obviously not the death in a dignified manner. I think COVID itself showed us that even if we die in presence of our family members who are feeding us, who are giving medication to us at the time of death and around the time of death, they are around us, and at least we whisper some words or even verses from our holy books. That makes a lot of difference. And people coming and just saying last final goodbye to the deceased person. I think that makes, in our context, particularly in Southeast Asia, a very dignified death. That is my take in the context of the COVID that we have recently seen.
Thank you, Dr. Majid. What you
Thank
said
you,
very
sir.
true.
Thank you. Sir, carry
And,
on, please.
and I think we will touch upon these. And in fact, I think Rutula has one of her later slides, the 10 things that signify a good death from a recent meta-systematic review. But first, what we will do is we will frame our discussion around the cases, so that then we can look at the broader framework, the ethical issues, the legal issues, and of course, the practical issues that come up when we are dealing with patients who are at the end of life, and how we can help them to die with dignity. So I will, Rutula, can I request you to read out the case?
Yes, sir. So the first case is of a elderly lady, a frail elderly lady, 82 years of age. She has been recently diagnosed with carcinoma esophagus, and she had dysphagia, especially for solid food, but was tolerating semi-solid and liquid. And she was planned for stenting because of the dysphagia. Now, when she presented to the OPD, they basically came for the planning and fitness for the stenting, actually. But when explored a bit more about what she knew and what is happening with her, her children were reluctant to let her know anything. But when asked, she said that I know that there is a small tumor, and because of which I am unable to swallow. But though she did not know that it was malignant in nature, the son and daughter were not very willing to tell her regarding that. So when the question of stenting came in, she very gently asked. She seemed like a very spiritual and Zen lady. So when asked, she gently asked, "Is it really necessary? I'm already 82 years old and liquid and solid foods जा रहे हैं, जरूरत है क्या stenting की?" So that was her question. The children obviously wanted everything to be done. Possibility of surgery was also being explored, and any further cancer-directed treatment was also being looked at. So my question to everyone present would be, what would be an ideal way to go about this situation?
So can I request all the participants to put their responses on the chat box, so that then it will give me an idea, it will give us an idea as panelists as to what their uppermost thoughts are.
This is, sir, always the dilemma for older patients, particularly like this case. We are encountering a lot of dementia patients, and the same thing happens. Sometimes some children are so worried, they want to do everything, and sometimes some people are so reluctant, they don't want to do anything. So we have to always question what to do for that.
Okay, so I have some responses on the chat box. Yeah. And
Most say
Oh.
that her wishes should
Yeah.
be respected.
Yes. And so Ipsita and Dr. Umesh and Dr. Hemangi, in fact, Dr. Hemangi says, let her die peacefully. Things should be carried out according to the lady. And Akshada, of course, says that they should be allowed to decide. That is, the patient should be allowed to decide if they are in the right state of mind. Patient's right to choose after discussing the pros and cons, and the need to break bad news. And Dr. Nimish Desai also says he agrees with Hemangi. And if the patient has intact capacity, is what Dr. Anisha says. And her decision should be final. And Veena Kantak says, explain to her kids the need for knowing and planning her life. And, you know, this thing about collusion, Ipsita says we must inform her about the malignancy. And then explain gently to her the need with repeated counseling and then decide. You know, I'm glad we're dealing with a group of psychiatrists because all of them have focused on, you know, the absolute right thing, which is to focus on the right to autonomy, the respect for autonomy, which is the cornerstone of the medical ethics that we practice. So yes, but at the same time, we know that in the Indian setting, collusion is a problem. And family members, even though this family was quite emancipated, and in fact, there was a niece who was a doctor, yet the children did not wish for her to know. And now, see what happens is, I mean, in a multidisciplinary setup, it becomes difficult to be the one to break bad news. In the sense that now I was the physician who was referred this case, and I was referred the case for fitness. So while talking about the fitness, I realized the many ramifications of the issue. And on speaking to the children had this to say that they've told her, "Ithe gaat hai." So there is a swelling there. But they had not told her about the cancer, like Rutula has pointed out. The niece pointed out that this lady is very spiritual and adhyatmika hai. That was a term she used. And she said that she will very easily agree not to do this. And the simple question that she posed really put all of us in a quandary. Now, when we deal with family dynamics like this, it is always difficult. And you may not have the luxury of talking to them, each of them independently, and exploring the issue. So now, right or wrong, what I did was I spoke to the family. I said that first looked at the issue at hand and said that if she has to undergo a stenting, then the stenting can of course be done. But if she's not having symptoms and if she's able to be with her symptoms, the first thing to do, like many of the participants have pointed out, would be to let her know the nature of illness so that she can plan her. Yeah. At the same time, I thought that doing the palliative stenting might give us some more time and also the family to come to terms with it and discuss it. So that was the compromise that I undertook during the interview with this patient and the family. Are there any more comments? Dr. Shubhangi, do you want to add something?
I feel what you have done is correct because I would do the same thing. In fact, I remember a patient again who was referred to me by Tata Memorial people because he was refusing treatment and he was 78 years old. Okay, it is interesting. He had laryngeal cancer and he smoked whole of his life. Okay, he said till the age of 70 I smoked. Okay, and he's from Konkan, you know, near my place, and he said he lived happily. Okay, and he, on the seashore he took, and he had 4 sons. Suddenly they came together, and he said he has to take treatment, and we are all willing, to contribute in the treatment. Now this person said, doctor has clearly, Dr. Vass, very famous oncosurgeon, told him that he may die on the table, he would lose his voice, he may deteriorate, but we would do doctors. Now all these things, if he was told, he had his own choice, and he said, see, I don't have money to spend on the operation, all these my sons would spend, and I don't want to burden on them, neither I want to suffer. Whatever life I have, I would live. And then I was supposed to give my reference answer to Tata Memorial people. So I said he should be allowed to go as per his wish. Okay, so probably they thought the patient has gone bonker, and probably psychiatrist also has gone bonker, but he lived next 6 months very happily in Konkan on the seashore. He ate his own cooked food, and he in fact invited me one fine day that you also come and I will cook. But he ultimately died happily, comfortably, with whole family around, with whole, all his village people around. I think that was a death which he wanted. So we really need to look at this particular aspect than what we think in terms of medically.
You're absolutely right, ma'am. In fact, in palliative medicine, when we frame the prognosis, we will frame the prognosis as, supposing with treatment he had lived for 9 months. Would those 9 months with suffering and going through chemotherapy, radiotherapy, or whatever surgery he might undergo, and loss of eyes, that extra time that he would have had, would it have been worth it? Would the quality of life of those 6 months, which you so aptly described, would have been better? And we need to frame it in that, which unfortunately, here at least this patient was referred to you because the patient was refusing. Otherwise, the patient would have undergone the treatment without really understanding the ramifications.
Yeah.
I think we have people congratulating you, ma'am, about this. And if I may ask you, ma'am, I mean, do you have you encountered collusion, or Rutula, do you want to just touch upon this problem of collusion which is there in Indian families and patients?
So it is present almost in all the patients, that almost all, not all, I would say, but almost all. Especially when I was working in Tata, majority of the patients who came in from like village side, and who were not so well read or literate, they would not know what their disease is. Even if when they're coming to like a cancer center, they would be like, हमें नहीं पता हमारी बीमारी क्या है, आप मेरे बेटे से बात करिए, आप मेरी बेटी से बात करिए. So that was the whole situation. We were like कि आपको कुछ जानना है, do you want to know what the disease is, क्या हो रहा है. लेकिन नहीं, आप उनसे बात कर लो, either the husband, son, or the daughter. So, or like vice versa, wife would be in case of a male patient, sometimes, not always. So it is very rampant, and many of the times the patients themselves don't want to know what is happening because they don't want to take the decisions for whatever is going to happen. They leave it up to their children, spouses, whoever is the decision maker. So it is very common in our setup. Sometimes it's not necessary to break the collusion, as we say, always break the collusion, get to the root cause of why they are not telling the patient, or why they are hiding some things from the patient. Sometimes we felt that it was not necessary to break it because breaking it would add to more distress in the patient. So we have let it be in many cases. Many of the times we tried to break it. Sometimes when the patient wanted to know, but the relatives, especially the children, were very reluctant to tell them the diagnosis or the prognosis of it, we would often say that, okay, because you're insisting that we won't tell, I mean, you don't want us to tell the patient, we won't tell right now, but in case they ask us what is happening, what is going on, what is the prognosis, kya hone wala hai, I would not lie to my patient because my priority is to my patient and secondarily to you. So, so that was how we kind of answered them. But yes, it is difficult in certain cases, especially when the person who is ill or who is sick is an independent, self-made, self-sufficient person, and you're not telling them what the diagnosis or the prognosis is. It leads to a lot of added anxiety and distress in the patient, just by the fact that they don't know what is happening and what's going to happen, and they are unable to take decisions regarding that. So yeah, it's a bit of a mixed picture that you get.
Thank you, Rutula. I was just going through the chat box to see if there are any more issues that are arising. So I can see that Dr. Umesh has posed a question. In case of terminally ill, in the absence of a living will, is it mandatory or advisable to assess the mental state or capacity to take decision before initiating any intervention? Now, before we address this question, Rutula, I'll let you address it in a minute. What I want to say is, the point which Dr. Nimesh Desai has brought up. So, he has said that the 21st century is the century of the rights of people. In fact, it has been the century before that as well. And the respect for autonomy has taken center stage above the other two principles of beneficence and non-maleficence. So as doctors, we may think that something is beneficial, something may be harmful, and we may weigh the benefit and risk and say that a particular thing needs to be done. But it always needs to be done in the context of the individual patient and his right to decide. So I think that's a very good way of putting it, that it is the century of the rights of people. And I feel that that is going to be a game changer. It's related to the question which Umesh also has posed, the right to make an advance medical directive. And so if I may point out, in 2023, the Supreme Court has given a landmark judgment. This judgment was first given in 2018, where they acknowledged that the right to live with dignity till the very end, or the right to die with dignity, they placed it in, they placed it equally with the right to liberty, which is enshrined in the Article 21 of our Constitution. And by doing this, the Supreme Court really put this record straight and made practice of dying with dignity that much easier. And having said that, then in 2023, they have simplified the procedure as well. So we'll go to that in a minute. So sorry, Rutula, I interrupted you. Do you want to respond to that question?
Yeah, I just wanted to say that if there is no obvious brain involvement or brain damage in case of a terminal illness, I don't think we need to get it certified that the patient is, able to take the decisions and all that. But it is always better. It will be helpful in the legal aspect of it after the death of the patient. So it's better to.
Rutula, I guess this has been framed very nicely in the Mental Health Care Act.
Yes.
And I was looking through it, and I'm sure the psychiatrists are also familiar. So if they may correct me if I'm wrong. So they had 3 words which describe the process of judging a person's mental capacity. So understand, appreciate, and communicate. So these are the 3 words used. This is from an article which I read about the capacity for mental health care decisions under the Mental Health Care Act by a person, I don't know him. It's from the Indian Journal of Psychiatry, Dr. Vasudevan Nambudiri. So the person in the patient should be able to understand what the disease process is and the pros and cons. Then he should be able to appreciate the course that the illness is likely to take. And he should be able to communicate that clearly with the caregiver. So if you can satisfy these 3 conditions, and then of course, in the Mental Capacity Act of the England and Wales and the NICE guidelines, there are very nice questions that you can ask in order to make out that mental capacity. And mental capacity is something which need not be done by a psychiatrist for this purpose. It can be done by any registered medical practitioner, because the process of taking informed consent involves this making sure that the person is competent to take a decision at that time and for that task. So both these are very important. So Umesh, do you want to ask a supplementary on this?
No, not really. You said it is very correct that he should be able to understand, appreciate, and communicate. Even even a dementia can
Sorry, Umesh, your voice is breaking. So there are some...
I said that these three things, if they are there, then there should not be any problem. And any RMP can assess that.
Right. Thank you, Umesh. So, there are a few more supplementaries on this consent business. So I'll quickly answer those, and then I'm going to ask Rutula to take us through the process of how we can help a person prepare an advanced medical directive. So, the consent issue, someone has mentioned the 14-year-old. So the 14-year-old who has refused to take chemotherapy, but is not yet of legal age to refuse consent. So here, this person, a 14-year-old, can, or you need assent of this person to continue treatment. So here, I guess the role of counseling and a psychiatrist would come in. And after that, a joint decision will need to be done after repeated counseling with the parents and the child. This is what I guess. Dr. Parker or anybody else in the audience wants to respond can.
I had a similar patient once in
Go ahead,
Tata. Again in Tata. So she was a 12-year-old child with AML, relapsed case actually, but receiving treatment, and her younger sister came out to be a match for the bone marrow transplant, but she outright refused that. Nothing doing, no way that I'm getting a bone marrow from my sister, and she was very adamant on that. And 12-year-old child, and we are trying to counsel. We had a child a therapist, a play therapist in the department, so we sat down with her. We had a senior child psychologist also sit down and just assess why she was refusing so adamantly. So what we got to know was that she was actually scared for her younger sister going through all the pain and all the potential infections and all, because she didn't know what it entailed actually. So she was like, my sister is not coming to the hospital ever. So that was the main concern. She was more concerned about her sister than her suffering, because she did not want her sister to go through all the suffering that she had gone through. So that was the reason why she was refusing. And till the end she refused. So she did not undergo the bone marrow transplantation, and she received some palliative oral chemotherapy post that, and she went back home to her native place. She was from, I think, UP. So she went back home, and we do not exactly know what happened thereafter, but she did not undergo the transplantation. So here I would suggest that maybe get to the root cause of why he's refusing to get not get the chemotherapy. It might be the silliest of reason that he heard from somewhere that this would happen, that would happen, especially in an adolescent age group. Even losing their hair might be like a big issue for them, like just because of the body image issues and everything. So it might be the silliest of reasons, but just try to get to the bottom of why he is concerned that chemotherapy would be harmful, and then maybe try to make him understand that it's not necessary that that would happen or whatnot, and how it is more beneficial to get the treatment and all that. That might help. But yeah, you'll have to get to the reason why he's refusing the chemotherapy.
So, Rutula, I would like you to just quickly take people through the steps that an advanced medical directive, in the way an advanced medical directive can be made. Maybe you can use the 5 wishes framework. And after that, we are going to have a very interesting question, which Dr. Nimesh Desai has posed to Dr. Shubhangi Parker about the famous Aruna Shanbha case. But first, we'll listen to the advanced medical directive.
So, according to the 5 Wishes group, it's an NGO who helps in the US, who help make advanced medical directives for patients. So basically, they have included that there should be 5 wishes that should be taken into account while making the advanced medical directive. So basically, you need to appoint a person who will take the decisions for you when you can't take the decisions yourself. So that person needs to be identified and documented that this is the person who would take the decision. So power of attorney should be given to the person. Then you should write down or make a note of what kind of treatments you want to receive and what not to receive. So do not resuscitate maybe, or do not ventilate, or no NORAD support if required, and all and whatnot. So all these should be specified. Then the symptom management, or how comfortable you want to be in the phase when you're dying. So you want to be pain-free, you want to be symptom-free, you don't want any breathlessness, you don't want any sort of distress, you would like to be put under sedation. So that also needs to be documented. Then you would just mention what you want from the people taking care of you. So how you want to be treated. You don't want certain things to happen when you're unconscious or when you don't know what is happening around you. You do not want to be just stripped naked and given a sponge bath without any privacy or whatnot. So basically, you just want to specify what kind of care and how that care should be given to you. And the last one is that who you would want at your bedside or near you when you take your last breath. So you want to, especially if it's in a hospital setting or in a hospice setting, whom you would want in the room or near your bedside when you're dying. So these needs to be specified. So any advanced medical directive should have these 5 points, and just make a very formal note of all these things and create a document which would then be put in with your medical record, so that in any time you go to a hospital, they know that you have such and such directive and you do not want these things, and you would want whatever to be continued and how you would want to proceed with the further care.
So in India, the advanced medical directive can be done by any patient, any age. The person does not need to be terminally ill. And these are the things that the person needs to keep in mind, this 5 wishes framework. And the help of the doctor is usually required in order to frame this. And of course, to know, for the patient to know that such a thing is possible, the doctor will obviously have to discuss it with the patient. And here is where we need to educate our physicians and primary care doctors in helping people frame their own advanced medical directives. And once the document is framed, it is as simple as signing it in the presence of witnesses, having the healthcare proxy or power of attorney sign it as well, that he understands it, and get it notarized by a judicial magistrate of first class, or any notary for that matter will do. And in fact, the first person to do this is a doctor from Mumbai, Dr. Datar. And we do have it on this presentation. And I think what we'll do is we'll share this presentation with Dr. Akshada, and she can share it with all of you. and also the references for many of these things we will share. So making an advanced medical directive is absolutely possible and can be done quite easily. So if there are any questions about an advanced medical directive, you may
Yes, sir.
please put it on the chat or ask.
Yes. With the same line of advanced directive, when should we are talking about ill patients and other things, but for the normal person, when should a person should think of like this dying with dignity, and when should they do the advanced directive or whatever? I think everybody should comment on this. Dr. Parker, madam, especially, I want your
Dr.
comment.
Shubhangi, do you want to?
Yeah, I mean,
Yes,
the kind of question you are asking is, when does end of life care begin, right?
No, no, not like that.
Yeah,
When
it's a difficult question. See, end of life care should begin when you need it, you know, whenever you need it, and may last a few days or months or sometimes more than a year, or whenever you decide. Okay, people in lots of different situations can benefit from end of life care, but I think it is the minute the need arises, one should start thinking about it. Okay, and some people may die within next few hours, days, and some maybe after the date. But I have here another experience which I must say. I had a patient who was depressed. Okay, depressed for years, right? And and the depression was not basically coming under control with a different kind of treatment, refractory line of treatment. And this patient got pancreatic cancer, okay, at the age of 45. Okay, and that was the time when patient started telling that he doesn't want treatment. Okay, he doesn't want treatment. Now the papers which were there having the diagnosis of major depressive disorder and on the treatment and the depressive disorder for years together, and with now the diagnosis of cancer and patient refusing the treatment. Now this issue was not digestible to oncologists, okay, because they felt that is the idea, probably patient is suicidal. Okay, that's the reason why he is refusing the treatment. Now this is a very important event which happened, and I was evaluating this patient, and understanding that patient was in total sense, basically of responsibility. He understood what was happening to him. He knew he was a depressed person, but he was clear, very clear about his cancer and why he doesn't want treatment. And I think there probably we really need to understand the patient in terms of their attitude, their behavior, and basically their value system, and this is something which is important, because I didn't feel that patient was suicidal, though he was suffering from the depression for a long time, was under our care. But here the need for preserving his dignity, to die comfortably, and not to, because he knew that his cancer was, he asked all those questions very rightfully, very understandingly, and having full insight. And then he decided that he doesn't want treatment. He doesn't want to go through suffering because of treatment. He wants to die peacefully. In fact, for me, I first time seeing the patient in control of his life, in fact, while he was facing the death, and this is a very, very important where I feel that ABCD of dignity conserving care, where you have to look at the attitude, behavior, compassion, and dialogue. And I agreed with him that with such a kind of terminal illness, he declining the treatment, and he's willfully going through welcome the death. So this was the real confusion between Tata Memorial oncologists and my patient and me, and it was again a very, very difficult case.
Thank you, Dr. Parkar. So, as a supplementary, a person has asked here. So I'm just going to read out the entire question. So what if some elderly person in good health feels that she has achieved all set goals in life, fulfilled all expected responsibilities, and doesn't find any motive in life now? Here, person isn't suffering from any medical or psychological issues, only has restrictive activities due to age and doesn't wish to be a burden on relatives or society. So he has not asked the question. So certainly, I think this person can prepare an advanced medical directive, but is this person's wish to end his life? I mean, is that what you're asking, Dr. Dhananjay?
Yes, sir.
Ma'am, can
Sir,
you?
recently I had came across, and that was interest. I am interested to ask SRP ma'am.
Yeah.
One patient came across last week, near about 72 years old man. Had a very wonderful life. He was been in a government employee, had achieved many achievements, rewards also in lifetime. He lost his wife 10 years back. And now he's staying with his daughter. And somewhere I find that he's not depressed, he's not anxious, but he feels that now nothing. I don't have to continue because I all fulfill my all responsibilities and roles in my life, and there is no motive in my life to continue. So, doctor, suggest me something.
So before Dr. Shubhangi answers, I mean, I just need to set the legal part clear that this would fall under the purview of what we describe as euthanasia. So euthanasia is active shortening of the dying process, and euthanasia in India is not legal at the moment. But ma'am, can you please touch upon this case and enlighten us?
This is very tricky, Dhananjay, very tricky case. Basically, because we really have to be careful and watch this person for some time. Dr. Shivkumar, what I feel, like suicide here in this patient also there is some kind of ambivalence. Basically when they say that they want to end life and there is nothing meaningful remain, that's probably was what is the Dr. Dhananjay's patient is trying to say, that there is nothing meaningful or there is nothing which can be done. So these kind of people, we really need to be careful because that ambivalence we need to observe. I probably will not be sure about this person. I would try to look at his value system. I would quite a few person I have shifted them, finding out that where if there is, I mean I'm again touching something which is different, a spiritual or something of that sort. If we can start turning that patient to that side. I mean, I will not be sure about this person that what he's saying is to be believed at this juncture. We really need to observe him for some more time, whether he is having loneliness, where he's having meaninglessness. We really have to look into the matter. Yes.
Sure, ma'am. I asked for the psychometric evaluation also, if there is underlying or any mass depression he's having. So I gone forward for this, and definitely I will observe him for the period and interview him time being for next 2 to 3 weeks. Thank you, ma'am.
So one comment in the chat box which I would like to highlight is Dr. Nimesh says there's a fine line between passive euthanasia and the right to die. So, ideally, I would not like to use the term passive euthanasia because, within it contains passive, and then I've defined euthanasia as active shortening of the dying process. So passive active. So it's like an oxymoron. So it is better to call passive euthanasia as withholding or withdrawing therapy or limiting life-sustaining therapy, and euthanasia as active shortening of the dying process. That is one thing that I want to say. Now, related to the question which Dhananjay has asked, and the clarification that Shubhangi madam has given, I would just like to say that, in the Indian tradition, there is this thing called Prayopavesham, Santhara. So these are, and someone has mentioned Samadhi in the chat box. So after exploring all this, and there has of course been some legal debate on this as well. But as of now, we still don't have a clear answer. Madam, would you like to
No.
say anything on this? No. Okay. So so let's go ahead then. I think we've had some discussion on collusion, on advanced medical directive, on the need to respect autonomy and probably place it above the beneficence, non-maleficence question. So consent is all important. And of course, we had some discussion on mental capacity and the things that are required for judging mental capacity. So Rutula, can we go to the second case? Because that will help us to answer some of the questions that we have when patients get hospitalized.
Yes. Next slide, please. So this is a 65-year-old man with end-stage COPD, is currently admitted in the ICU with tracheostomy in C2 and on ventilatory support. We have not been able to wean him off the ventilator, and home ventilation was also not an option because he was not maintaining the oxygen levels on that. Then previously he had a history of multiple hospital admissions for exacerbation of COPD. And current stay has been more than 2 months already. And at the moment, he was just skin and bones. There was absolutely nothing else. He's unable to talk because of the tracheostomy. And any sort of movements, like even changing of posture, would lead to a lot of breathlessness and a drop in saturation immediately. So because of all this, he is really restless. He was in pain because of, just bones, right? So and continuously lying flat on the bed was painful. He was distressed. He cried often, unable to express what was going on, what he was going through. The family members were mainly his children. That was his 3 sons and wife, and their wives also. They know what the situation is, that, the lung is not functioning anymore, and, the situation is very bad. But they still feel that he would get better and he would be home after the whole episode. And that's why especially the eldest son was unable to take the decision of just withdrawing the ventilatory support. So what should be the plan ahead? Like how to go about it? How to manage the children especially?
So can I request participants to put their responses on the chat box?
It was mainly gestures. He is conscious. His mentation and other systems are all fairly okay. It is mostly gestures. He tries to speak, but the voice does not come. So, and he's unable to write because there's absolutely no. He's very fatigued, so he's unable to write it down.
So here, the third aspect of communication is hampered because he's not able to exactly communicate what he wants. And we are not sure whether he understands and appreciates what is happening. And so we are in a kind of limbo kind of situation where we're not sure. And at the same time, the family seems to be inclined to continue and is not able to come to terms. And I can see what people have suggested in the chat boxes to do repeated sessions of counseling and work at seeing if you are able to get greater clarity with what the patient wants, and maybe providing him symptomatic relief. So these are the issues. And Dr. Rutula, can you just tell us what happened finally and how this case?
So it persisted for a long time. So almost another 1 month went by before they took the decision of shifting him home on oxygen, and then whatever happens. That was the decision. But he did not survive the weaning off of the ventilator. So he died eventually in the hospital itself, but it took another month to do that. And
how would you prevent symptoms in a situation like this? I mean, how would you provide symptomatic support? So for breathlessness, for the other.
So for breathlessness, we had already started him on strong opioids. He was on fentanyl infusion continuously. That was also titrated according to the need for his pain and the breathlessness. But any sort of movement just exacerbated it, despite the infusion going on. So there was not much that we could do for the movement related breathlessness, but he was as comfortable as we could make it given the whole situation. We did try to communicate with him using yes and no questions. How is the pain? Is it better than yesterday? So yes and no, he would just nod and shake his head. So that was how we communicated. So we couldn't explore a lot more because we just had to ask yes and no questions. But yes, we did try to communicate with him.
So
yeah.
No, so you're right, Rutula. So the point that I wanted you to bring up is about using opioids for relief of terminal breathlessness, which kind of seems to be counterproductive because it will reduce the respiratory rate. But the treatment for terminal breathlessness, in order to provide comfort, would be to use opioids. And similarly, Dr. Nimesh Desai suggested, can we use cannabis or marijuana for relieving the breathlessness? Not that I'm aware of it.
Not for breathlessness, sir. It's mostly for pain, but not for breathlessness.
Okay.
And sometimes used for appetite like as an appetite stimulant, but not for breathlessness. Yes,
okay.
And the thing is that it's not easily available, and also it's usually available in oil formulations. So calculating the dose is very tricky.
Okay.
So most of the patients land up with high instead of relief from symptoms, which are more distressing in certain patients.
So, many people in the chat box have pointed out that we need to have repeated counseling sessions. Dr. Dhananjay has suggested that we should ask the family to take a second or third opinion, which we did do. In fact, not just from our hospital, multiple people from our hospital, including the pulmonology, the medicine, and people from outside were also asked. But unfortunately, sometimes this kind of conflict can linger on and make decision-making difficult. At this point...
I have a question, because
yes,
this is a very important consideration, Dr. Iyer, because what happens, the patient may die, but later the family, keep feeling a long-term guilt, and this is a very important consideration that, probably we were not told adequately enough by doctors, or we were not given enough explanations. That's why we were not able to take, but that guilt remains for a long time. This is this is a very one of the important aspect of dying with dignity, where the family suffers because they are also clueless, and they are also helpless at that juncture.
You're absolutely right, ma'am.
So actually, we almost every day we would counsel the sons almost for an hour each. And we would try to, make them understand the current situation and everything. But the main decision maker was the eldest son. And he was very adamant that we should continue for another day. We should continue for another. So, that another day just went on and on and even at the end of it, it was very difficult for him to take the decision to take it off, take his father off the ventilatory support. But yeah, it was like, log kya, more, not even log kya kahenge. It was, I think the father was the main pillar in the family, as in he was very active and he had brought them up since childhood. So he was the main sole bread earner in the family as well. And according to what history that I received when during the counseling session was that he would carry 2 buckets of water to the 3rd floor, I think 1 or 2 weeks before he got admitted. So it was like a sudden drastic change in, his scenario from just 2 weeks prior to being bedbound for more than 3 months at a stretch. And, so that was kind of hard for them to digest as well. So it was more of like, log kya kahenge was there, like, the other people's opinion do matter, especially in our society. But it was more also that, such sudden change cannot occur. There's a possibility that he would just recover. It's just, thoda sa zyada infection ho gaya hai, and he would recover. He'll just need some more time. So that was the whole understanding of what had happened with his father. So it did take a long time.
Yeah.
And
I'm
we
going
were,
to, yeah, sorry, Rutula. So I'm going to ask you to, explain the process that we follow when we have to withhold or withdraw in the hospital, and how tedious it has become. But before that, Dr. Nimish Desai has said that the American guidelines are in support of tetrahydrocannabis for breathlessness. So we will definitely check it out. In India, though, the medicinal use of marijuana is not
very well
very well documented, but certainly we'll check it out, sir. Thank you so much. So, Rutula, do you want to just tell what happens when we are making that decision, and the steps that we take, and the documentation that needs to happen for withholding or withdrawing therapy? And then, we will ask Dr. Parker, madam, to comment on withholding, withdrawing therapy, especially with regard to the Avinash Ranbhag case. Yeah, please tell us what the current situation is regarding withholding, withdrawing therapy in the hospital.
So the current guidelines, according to the recent Supreme Court judgment, says that we need to first establish the futility of further care in the patient, in the given patient. We need to understand that further treatment won't be of any added benefit and would just be prolonging the life of the patient without any benefit to it. Once that is established, there is a first level committee which comprises of 3 experts in the field from the hospital itself, and one would be directly involved in the case that we are seeing, but the other 2 won't be directly involved in the care of the patient. And if they also come in consensus that yes, it is no longer of any added benefit to continue such and such treatment, then this is then discussed with the family members or the surrogate decision maker or the main decision maker. And if they are also in consensus, and this all is documented as we go along. So once the family is also on board, the second level committee is set up, which will consist of a state appointed medical officer who may or may not be from the hospital. So a state appointed medical officer and two other experts in the field who are not involved in the care of the patient. And they would again recheck the decision of discontinuing the life-sustaining treatments. And if they are also in consensus with that fact, then again the family consent is taken to withhold or withdraw the life prolonging treatment or life sustaining treatment. And then that is done according to the wishes and the preferences of the patient and the relatives. So according to them, like,
yeah, and then finally we have to communicate it to the district judicial magistrate. So this has not really been done exactly in this format so far, but it has become easier than what it was before. And the medical experts previously needed to have 20 years experience. Now they need to have just 5 years experience. And it has become much more feasible. Previously, the second medical board had to visit the patient. The district magistrate had to visit the patient. So all those things have been taken away. And I hope that this simplification of process will help us document this end-of-life care better. Rutula, thank you so much. There is a question for Dr. Shubhangi Parkar, and Dr. Dhananjay asks, can you elaborate on dealing with the grief or bereavement of the relatives of such patients? It may not be acute grief. It might be anticipating or anticipated grief, but it is still hard for relatives and how to handle. So, ma'am, along with this, if you could also touch upon the Aruna Shanbhag case.
Dhananjay, this is a very important perspective, because this grief remains lingering, and people, years after the death of their beloved ones, they continuously keep feeling that. I think this is where perhaps the open communication from physician, which is a very important. I mean, if this dialogue happens before the terminal events ends, this is important, because I myself have gone through this particular experience twice in my life. My sister had a bone marrow transplant from Tata Memorial Hospital. She ultimately died because of the graft versus host disease, and that was, as a doctor and as my whole family always felt guilty that whether that decision of going ahead with the bone marrow transplant was correct one, and because there was a lot of suffering. Eventually, over the time, we kept thinking, but eventually we discussed on it. After my sister's death, we went through that discussion for a longer time, because the guilt was really troubling. The day-to-day living was difficult, and that is the one important perspective which is, and that gave me later the courage to take decision. When my mother was dying, she had a renal failure, and again she was for 6 months in the hospital, and she expressed it after having the daughter's experience, that I don't want to be on life support if there is not going to be any change, and if I'm coming to that particular end, so don't trouble me. So I think that was very easy eventually over the time, and that's how we survived. I think these personal illnesses perhaps makes things little more insightful. About Aruna Shanbhag in KM, yes, I mean she has been there for 35 years or something like that with us, and initially, Nimesh, we never thought about laws or legality. It was almost the humanistic approach which was shown by our nurses, our doctors, and she remained healthy physically. Okay, otherwise she wasn't conscious, she wasn't aware of the things. But then there was an issue which happened, because when the guardianship issue came in the picture, I think the case went to Supreme Court, and Supreme Court has given the decision that guardianship goes to KM, because nobody else was coming forward. And she was taken. She's one of the very rare case in the world which is being looked after on the humanistic consideration by colleagues and the doctors and hospital. So eventually she died of infection. But yes, I think in Aruna Shanbhag case, we face a lot of journalistic comments, and people probably came to the level of that she is suffering because KM hospital is not allowing her to die. So many issues came, basically. But that was a big battle. But that was probably, we went through humanistic medicine. In fact, KM started the whole concept of humanistic medicine is because of Aruna Shanbhag's experience.
Oh, thank you. Thank you so much, ma'am. And it was the High Court, and Justice Kadju was the person who delivered that landmark judgment.
Yes.
And what the case did was to frame the debate around withdrawing therapy in patients who are terminally ill, not only patients who are terminally ill, but also in those who had a persistent vegetative state. And here, like you rightly pointed out, the guardianship was with KEM, as the parents were not visiting the case at all. And so therefore, I think the court did the right thing by saying that the care at that point needed to be continued. Eventually, she, of course, died of an infection, like you pointed out.
Yes.
Thank you so much, ma'am. I'm just seeing if any other questions are there. If there are no other questions, we have about 10 minutes left. If I may just ask Rutula to, the last 3 or 4 slides she has, they will help to summarize the discussion that we've had. And if there are pressing questions,
Sir, can I come in comment?
Sure, please.
I want to congratulate KEM team, specifically medicine department and psychiatry department, who has taken care of Aruna Shanba.
Yes.
A very, very, very human kind of gesture they have given, and all the nurses and very confidentiality and very. I know that I used to take rounds with the SRP ma'am, so she was been care at the most like a family member in that ward. Yes.
You're absolutely right. Hats off to the KEM team, and
Sure.
especially the nurses. I mean, as doctors, but the nurses used to be with her, and I read about this case a lot because one of the essays that I wrote for my MSc in palliative was about Aruna Shanba. So yes, I mean, hats off, absolutely hats off to the KEM team. Thank you so much, Dhananjay. Thank you, ma'am, for enlightening us about this. So, Rutula, can you put up your next slides, and then we can...
Next slide, please. So coming to what a good death entails. So obviously for every individual it is different and might mean something else and may have certain needs which are specific to oneself. But most of them are included in these 12 subheadings. So obviously everyone would like to know when a death is approaching and to understand what should be expected when that time is near. So it should be an expected death. Then you should retain a certain amount of control over what is going to happen and how things are going to go. So let's say, I want to be in a hospital instead of at home. I want to be in a hospice instead of an hospital or at home. So, certain level of control over what and how things are going to happen. To be afforded dignity and privacy. So they should still be treated as a human being rather than like that pancreatic cancer patient. So, they should be addressed with their names instead of bed number 8, so certain things like that. So they matter a lot. Then to have control over their symptoms and symptom relief should be present, especially pain, because no one wants to be in pain, especially at the end of their life. Then to have a choice and control over where the death should occur. So as I said, in an hospital or at home, surrounded by everyone, or certain place that they want to go and, they want to die at that particular place. So to have a choice over that. If they want, then to have access to information and expertise in the field of whatever they want to know or want to have in their care. So if they want to know, let's say in our setting, if they want to know the prognosis, then they should be given that information so that then they can take certain decisions which are important to them, which might not be as important to the family members or the caretakers, but are very important to them as a person. So they feel that, okay, SSA hone wala hai, so I should take those decisions right now. So that kind of information should be given to them. They should have an access to any spiritual or emotional support that they require. So if they want to go to, if feasible, if they want to go to certain temple, let's say, or to go and visit some relatives, they should be encouraged to do that if it is feasible. Like, as I said, if it's not physically possible for them to go to a certain temple, then that might not be possible, but certain way around it, maybe showing a video or something of that sort. So, just to get a, peace in their head that, okay, I have done whatever I needed to do. Then to have an access to hospice care in any location, not only in an hospital. So this is very difficult, especially in our country where we don't have a lot of hospices, especially for non-oncology patients. So it's difficult to do this, and most of the care is being taken in the hospital, as at present at least. So at least to have a good hospital policy about palliative care or geriatric care or end of life care, so that unnecessary aggressive management or unnecessary aggressive treatments are not being done on these patients. Then to have control over who is present and who shares the end. So again, as I mentioned before, who should be present when they are dying, or who should be there during their last moments to maybe talk a few things or get the last few important messages across. Then to be able to issue advance directives. So this is an extra one which I added because it was important that we have that advance directives in place, so that there's no further complications once they get into the hospital. To have time to say goodbye and to control over other aspects of the timing. So one of our faculty would always say that, they should be able to tell someone goodbye, I love you, I forgive you, thanks for everything. So, so those kind of things that they should be able to do, that should be able to express those things before they take their final. And then to be able to leave when it is time to go and not have their life prolonged unnecessarily. So that would be sort of comprises everything that a good death should be, but it might be different for different people, and some might take a priority than the rest of them. So it's always good to mention, as I mentioned before, for advanced medical directive, it's always good to have what are the 5 most important things highlighted, so that those are carried forward when the care is being taken. Next slide, please.
Rutula, I think we can be at this. We've just got about 5 minutes. Yeah. And so there's one question which has been asked by Veena Kantak. She says that in the book Death and Dying, she says that we are scared of breaking bad news or terminal illness due to our own prejudices and fears about death, which is so true. I think, as medical professionals, we have medicalized death, and the fear of death that we ourselves have and the desire to continue is so strong that it prevents us from taking appropriate decisions. So the experience has changed. Definitely, it has changed me. And in your good death, the points about good death, Rutula, there is one more point, I think, which says that, developing a deep understanding of life and death and being able to understand it all, sort of, arrive at a closure, not only in terms of the actual things that we do but also within internally. So this is what I wanted to say. And I would request Dr. Parker to give any final comment if she would have. And then Rutula, one final comment from you, and then we can close the session. Ma'am?
Yeah, I think it's a difficult topic, and every time you go, you feel you could have done more for your patient or for your client. It's a very honest, open, and respectful way of dealing with these clients, in our culture. I also have taken a lot of, a way of looking at the spiritual way. I mean, there's somewhere, the people, especially in geriatric population, looking, some of the things which Rutula has mentioned there, that really helps, basically being grateful to the God, for being in the life. And I have used that. I mean, I like that Buddhist philosophy, that you have to live the life when it is without problems or without suffering. When suffering makes life difficult, that's the time, just to think that to say goodbye, basically. Yeah.
Thank you, ma'am. Akshada, Rutula, do you want to say anything, or shall I hand over to Akshada for closing the session? Yeah. So Akshada, over to you, so that you can close the session.
Thank you so much. I think you did the job of handling the panel very well, Samir. I didn't have to do anything in that. The questions are already answered. I think no more questions are remaining unanswered in the chat box. I was just going through. Anybody has any last questions? We can take it like for 2 minutes, like some few questions, 2-3 minutes. Anybody wants to speak?
Not a question, but a comment. Excellent presentation by Dr. Iyer and Rutula, and very great contribution by SRP ma'am. And thanks geriatric committee for organizing these things. It has been very 1 hour, 1.5 hour was
1.5 hours.
means, yes, 1.5 hour is the brainstorming. You really realize, and we can see that how it's not for our patient, it's for ourselves, what I feel.
Of course. So we didn't realize how the 1.5 hour has passed, and I think it was a very interactive session. Everyone has participated. Dr. Iyer has allowed everyone to participate in between the talk. That was really nice. I would like to ask Dr. Nagapurkar, sir, you want to say some words, a few words? So it was sir's idea to come up with this. If sir could say a few words.
Yeah, because
Yeah, definitely.
Yeah, Umesh,
I
please.
would take that privilege, and formally I would like to thank Shiva, Rutula.
Sorry, Umesh, we've lost you.
Yeah, I'm joining now again.
Yeah, you're there now.
Recording in progress.
Yeah, sorry because there is some issue with my laptop.
We can hear you.
Yeah.
Now we can hear you, sir.
Yeah, so basically I would like to thank Shiva, Rutula, Sonone and Dr. Mrs. Parker madam for a very thought-provoking, insightful discussion in this very different, jara hatke topic. Okay, because this is not a usual psychiatrists would discuss within themselves or with any patients. I thank Akshada, Amar and Geriatric Subcommittee for organizing this. Thank Yogi for organizing this Zoom meeting very well. We had a very good discussion, 2 cases basically, practical experience from people who are doing this regularly, and practical aspects of processing or facilitating this issues regarding death, issues regarding handling relatives dilemma, and also important issue of grief. And I must appreciate active participation by all participants. And we had a pan-India presence, not only West Zone psychiatrists, but pan-India. Our colleagues joined this in this interesting discussion. Taking it further, we plan to have another session for general public, because this was basically to sensitize psychiatrist population. But we would like to take it to general public also, because this is an important issue. And in next Gav Tethe Manasopchar edition, we are having geriatric mental health as a main theme of that program. So in that, we try to incorporate this. And Shiva, we would be welcome you for that program also. And thank you so much. Thank you. Bye.
Thank you.
Thank you so much, sir.
Thank you. Thank you. Ipsita has asked a very difficult question on
Yeah, I was just seeing that.
depression. Yeah. And so I think, Ipsita, we are towards the end. And so maybe you could ask this to Dr. Parker, and Rutula has responded.
That
by
was
saying-
my response. I was just typing.
It will be his right to take any treatment for his or her disease and continue only palliative care, and hopefully she dies with dignity. So I think it's a difficult thing, and there are many questions, and especially we've not touched upon coping mechanisms for grief, and so I think those maybe in another session. Thank you so
Sure,
much.
sir. So we'll be happy to have you again, sir. Thank you so much, sir, and thank you, Dr. Rutula. Thank you, Dr. Shubhangi Parker, for being there and giving such wonderful discussion today. Thank you so much. We would like to hear you all again in the future. Probably we'll get back to you. Thank you, sir.
Thank you.
Thank you, everyone.
Thank
Thank you,
you.
everyone.
Thank you so
We
much.
have,
Thank you for the opportunity.
Shiva, we have recorded-
Congratulate Akshada, Amar for
Yes.
having wonderful session. Thank you very much.
Thank you, sir. Thank you, sir. Thank you for your support.
Recording of this would be available on our YouTube channel. So
YouTube. Yes, sir.
anybody, yes.
Yes. Thank you.
Yeah,
Umesh.
Yogendra said YouTube.
Yeah. Thank you.
Thank you, sir. Good
Thank-
night, everyone. Good
Yeah,
night.
Good night.
Good night.